Welcome to the PCMH Practice Innovations May 2015 webinar. This webinar will be about the patient-centered medical home project that the PCMH is assisting practices with across the state. And today's presentation will be specifically about Standard 1 of NCQA's PCMH 2014 guidelines. I want to especially thank Claudia Cartledge and Jenna Rogers for their assistance in producing this presentation. And I also want to mention that because this is not a live webinar, please feel free to email me if you have any questions, concerns, or feedback. My email address is scotth@scmedical.org, scotth@scmedical.org. Standard 1 Element A in particular is all about how do patients access your practice. We will be talking a lot today about how patients get access to your practice, and this is a very important issue in South Carolina as we are a rural state, and even in urban areas, patients have difficulty at times getting access to their physicians when they need medical care. So what NCQA does is they help us think through what kind of access are we offering our patients, and then quantitatively, in many cases, measure the kind of access that we're providing our patients. And then it really helps us to ask the question, how can we improve? And much of what we talk about today will be about steps that we can take to improve and how NCQA requires us to move through those steps. As you probably know, NCQA's 2014 standards have 6 standards. We will be talking this month about Standard 1 and then in following months about the other standards. The focus today, though, will be on access to care. And the intent behind NCQA Standard 1 is helping practices provide access to the patients, families, and caregivers for routine and urgent care needs at all times of the day and night. One thing I do want to emphasize from the start is some of the things that NCQA requires may be either difficult for your practice or next to impossible. And in some cases, you don't have to do those things. And we'll talk about that along the way. There's very few things that are absolutely required, and we'll also emphasize those points as we go along through this presentation. This is what Standard 1 Element A looks like on NCQA's guidelines. And basically the way this is organized, if you look at the black bar that says Element A, that bar describes what the element is essentially about, which in this case it's patient-centered appointment access. And if you see it says must pass, that means that NCQA requires practices to pass this particular element. There's 2 other elements in Standard 1, B and C. You could actually ignore those completely and still pass NCQA's 2014 standards. But you can't ignore Element A. This is one you have to pass, and under NCQA guidelines, a passing score is a 50%. If you look down at the bottom, there's a scoring column or a scoring row. If you see the 50% number, underneath it says the practice meets 2 factors, including factor 1. So to pass this element, you have to do 2 out of the 6 factors that are listed there. And out of those 2, you have to do factor 1, which is providing same-day appointments. So the way we're going to structure this webinar is we're going to go briefly through Standard 1 Element A, B, and C, and then dig a little bit deeper into how we prove that we're actually doing elements A, B, and C. Because it's one thing to be able to do elements A, B, and C. It's another to be able to put it on paper for NCQA to judge you and affirm that you are doing what they are wanting you to do. And a lot of what our PCMH Practice Innovations program does is comes in for one-on-one practice coaching assistance to help you think through not only the changes that need to be made to comply with NCQA guidelines, but also to think through how do we actually report this, and we can help you with reporting. And we'll mention that along the way as we go through this presentation. So just briefly, Element A is all about how do patients get to have appointments with your practice. If you look at Standard 1, it's about same-day appointments for routine and urgent care. And we'll talk more about that in a little while. Factor 2 is about providing those routine and urgent care appointments outside of regular business hours, which many of you probably already do. Number 3 is about providing alternative types of clinical encounters, and we'll talk more about that later. But this may be one area where NCQA is a little bit ahead of South Carolina and the payers. A lot of payers are not reimbursing for alternative types of clinical encounters, and so it makes it cost prohibitive in many cases to offer these kind of services. But if you do have payers that are willing to engage with you and reimburse, this may be a great alternative for you. Then number 4 is NCQA wants you to measure how long does it take for patients to get appointments, specific appointments like a sports physical or a well visit or a Medicare wellness visit or a diabetic follow-up visit. Whatever kind of specific appointments that are important to your practice, NCQA wants you to measure how long does it truly take patients to get access to those appointments, and then wants you to monitor that over a period of time. Number 5 is about monitoring no-show rates. So this is pretty obvious. It's looking to see what your no-show rates are in your practice. But this is one area where you may have a qualitative feel for how often patients aren't showing up. But in most cases, practices have never actually performed quantitative measurements to determine what their actual no-show rates are. We'll discuss more later why this is important. And then factor 6 is about looking at the numbers, quantitative numbers that you've produced in the first 5 factors, and seeing areas where you may want to improve. For example, when you monitor your no-show rates, you may discover that you have an 18% no-show rate. And factor 6 gives you an opportunity to implement a quality improvement project to try to get that 18% no-show rate down to a level that you think would be more acceptable. Let's dive into these particular factors. We'll go through factors 1 through 6 in a little bit more detail. This slide describes what NCQA is looking for when they want you to prove that you're actually meeting the same-day appointments. So factor 1 is all about same-day appointments, and one thing that NCQA does not consider a same-day appointment is a work-in. So work-ins are not considered a same-day appointment under NCQA standards. The way NCQA defines a same-day appointment is it has to be reserved in advance and available that morning. And so what NCQA wants you to do is have a documented process, kind of like a policy, about how you implement same-day appointments and how you reserve same-day appointments. This is actually pretty easy because you just ask yourself a question. How do we do same-day appointments, or how do we handle same-day appointments? And whatever your answer to your question is, that's your policy. Now, if you don't reserve appointments, same day, then you're going to have to make some changes. But most practices I've worked with over the past year and a half or so, they all do some kind of same-day appointments that they reserve in advance. And so once you have that documented process written, then NCQA wants you to produce a report that has 5 days of data that shows the availability and use of same-day appointments. And this is for both urgent and routine care. And I've got a slide that's going to be coming up right now that shows an example of what we've used in the past to prove to NCQA that we are providing same-day appointments. And what we typically do is we'll take a screenshot of a week's worth of appointments showing the appointments that were reserved, and then we'll produce this report. And this report will indicate how many appointments you had and how many same-day appointments were scheduled at the beginning of each day. NCQA's changed it up a little bit in 2014, so this is a 2011 report. The 2014 report, instead of having number of appointments, all types, would have number of same-day appointments available, and then the next row would be number of same-day appointments filled. And one really easy way to do this is to, for a week's period of time, let's just say Monday morning, you look at your schedule and just count up all your reserved same-day appointments, and then you fill that number in to the slot there, and then you, at the end of Monday, count the number of appointments that were filled, and you fill that number in. And we actually have developed templates that are specific to 2014 that will enable you to fill in the blanks, and it'll make it real easy for you. One thing I do want to mention is most of our examples will be about the 2011. These specific examples like this will be about the 2011 standards, and that's because the 2014 standards are pretty new, and I'm not sure any practices in South Carolina have yet applied under the 2014 standards. So these examples will be from 2011, but they will be very similar to what you'll have for 2014. So once you have your documented process and your report, you're ready to move on to factor 2. But before we move on to that, I do want to mention a few things about same-day appointments. When I meet with practices, in almost every case, they have more appointment requests same day than they have reserved. For example, I met with 25 practices over the last couple weeks, and I asked them this question: do you reserve same-day appointments? And they uniformly said, yes, we have same-day appointments reserved for patients. And then I asked, do they always get filled up? And every single practice said they always get filled, and we actually have more than we can handle. And so this is just something to think through in the long term, but it may be good to take a step back and think through, can we offer more same-day appointments to patients? And one good reason for this is that this really will enhance your access, your patient satisfaction. It will keep patients in your practice. When a patient calls and needs assistance, a lot of times it's that day, and if you don't have room for them, or if a work-in results in a multiple-hour wait, they're going to go to urgent care or to the emergency department, which fractures the medical home. And we really want to keep our patients in our practice for a number of reasons. And so it'd be good to think through offering same-day appointments. Also, same-day appointments help reduce no-show rates. Practices that have more open access scheduling have seen a decrease in studies of no-show rates from 52% to 17%. So there's a lot of good reasons why you may want to think about having more same-day appointments available. And it's the kind of thing where you can break in gently. You don't want to go from 2 same-day appointments a day to full open access scheduling in 1 week's time. You certainly want to work into it over time. But this is one area where we could really, I think, do a better job of providing easier access to our patients and preserve the integrity of the medical home at the same time. Let's move on to factor 2. And factor 2 is about providing appointments outside of regular business hours. This is, again, one where NCQA requires a documented process, and they also want to see a report of 5 days showing the availability and use of appointments outside of normal office hours. Most practices do offer appointments outside of office hours, so this won't be too much of a problem for you. But for those of you who don't offer access, this may be an issue for you, and you may need to work with, and many of you probably do, like an outside service. The one difference for this 2014 standard is this is actually an appointment and not just giving access to patients to be able to call you. And so what a lot of practices do, and I've got an example of that in just a second here, they'll just expand their hours a little bit in the morning and in the afternoons. This practice here, if you look on the bottom right-hand corner of their patient brochure, they opened their practice a little bit earlier on Mondays and Wednesday mornings and had their practice open a little bit later on Tuesday and Thursday afternoons. And this would be an acceptable way to have appointments after office hours. Now, if you recall what I said earlier, you don't have to do all of these factors. So if the extended office hours is something that's too difficult for you to do, then this is something that you just would avoid. But I will say that, again, patients typically need access before and after office hours, and the more that you can accommodate the patients, the better patient satisfaction that you're going to have. You're going to be able to maintain patients over long periods of time. You're not going to lose patients to other practices as a result. And in a competitive marketplace, this is one area where a lot of practices are starting to extend their hours. Let's talk about factor 3 for a second here. Factor 3 is all about providing alternative types of clinical encounters. Again, as I said earlier, this is not something that is very prominent right now, particularly in South Carolina, but it's growing. There are some advantages, though, to offering alternative encounters. And what NCQA wants you to do is have a process for arranging alternative appointments. And these are things like telephone visits, group visits, video chatting. There's lots of ideas that you can come up with. I would say the group visit is probably the most common one that we've seen growing across the country. And we'll talk more about that in a second. But what NCQA wants you to do is not only have a process, but also have a report that shows how often you're actually using these alternative types of encounters. And they say specifically that ad hoc telephone and email exchanges don't meet the requirement. Shared medical appointments, like I said, are one of the more common ways that people are doing these alternative clinical encounters. And it's particularly valuable for patients with chronic conditions. And that's because patients will have, as a whole, more time with their physicians. If you think about it, when a patient comes to see their physician, oftentimes it's got to be a pretty quick appointment and there's not a lot of time to spend. But if you're able to combine 10 or 15 patients into one visit, because you're seeing so many, and hopefully the reimbursement would be commensurate with that, you'd be able to have a longer period of time. Even though it wouldn't be one-on-one, it would be a longer period of time with the patients. It also allows patients to support one another to come up with good ideas. It can help mitigate your own demanding schedule as a physician. So all in all, there's a lot of good reasons to do the shared medical appointments, but again, if the payers are not reimbursing this, it is difficult to offer this if there's no reimbursement for it. So this is one where you may have to skip this one, but if you look at the scoring, you can skip one of the 6 factors from element A and still get all the points. Because I think NCQA recognized that there were some things that practices just weren't going to be able to do. Let's talk about factor 4. And this is where NCQA wants you to measure the availability of appointments. And so, for example, you probably have a number of different appointment types, like routine exams, new patient physicals, urgent care, return visit exams, well woman visits, Medicare wellness visits, you name it. It's likely that you'll have a number of these kind of visits. And what NCQA wants you to do is they want you to define how long do you think patients should have to wait for these specific types of appointments. So for example, for a sports physical, maybe you would say a patient shouldn't have to wait more than 10 days to get a sports physical. And then what NCQA wants you to do is start measuring how long it takes for you to set these appointments for patients. And it's over I think it's over a 5-day period of time showing what appointment wait times are. So what you'll probably have to do is get your appointment schedulers to have a manual log where they, as they're setting these appointments, they're recording probably on an Excel file. You could even do a manual written worksheet. For a week's period of time, they would record how long when a patient calls in for a sports physical or for a wellness visit. When they set the appointment, how long or how early was the earliest available appointment. And this is one way to quantitatively determine how long are patients having to wait in order to see the clinicians in your practice. And this is a really important factor because the longer patients wait, the more likely it is that they'll go to another practice or seek alternative types of care, which then again disrupts the integrity of the medical home that we're trying to work towards. Did want to mention briefly that Medicaid has been reimbursing for primary care at the Medicare reimbursement rate for the last couple of years. They've continued it beyond what the federal government required them to do. We would love to hear your feedback. Again, you can email me at scotth@scmedical.org. And the feedback that we're looking for is this enabling you to see more Medicaid patients? Is this providing better access to Medicaid patients in your practice, the fact that the reimbursement is at a higher level than it was previously? Or is it not having impact at all? We'd love to get your feedback on that as we work with Medicaid officials on these issues. It'd be great if we could share some of your thoughts about how this reimbursement is affecting the access of Medicaid patients to your practice. Let's talk about Factor 5. Factor 5 is monitoring no-show rates. And again, this is very similar to all the other factors. What they want you to do is have a process for how you're going to monitor your no-show rates. And then over a 30-day period, they want you to monitor your no-show rates so you can actually develop a percentage, and then you're going to report that percentage to NCQA. And there's a lot of ways that you can do this, but certainly if you can do a retrospective chart out of your EMR or do it real time each day, and we can work with you to find the easiest way to record this for NCQA. But another thing that you want to think about when you're recording this is you're going to want to think about, let's look at some of our demographics so that we can identify, are there specific patient groups that are having worse no-show rates than others? And one reason you want to do that is when you start working on improving your no-show rates, if you've got a certain segment of your patient population that is really almost perfect across the board on coming to their appointments, you're not going to want to focus your efforts there. You're going to want to focus your efforts on those patients that For example, let's say when you measure, you find out that Medicaid patients are your highest no-show rates. Well, you're going to want to focus your efforts on your Medicaid patients. And if you were to focus your efforts on your Medicare patients who might have great no-show rates, then your extra energy and effort is going to go wasted because it's the Medicaid patients that you're looking to improve on and not your Medicare. So just something to think through as you work on projects. And some ideas for how you could break it down is by race, by insurance provider, by age, by access to transportation, by reason for the no-show, missing the no-shows. And we've got a couple recommendations as we go through this PowerPoint presentation today about how to address no-show rates, because it can sometimes be confusing about what can actually be done for addressing no-show rates. And one way in our research that we found can really help is text messaging. Folks are a lot more likely to read their texts than they are to respond to your phone call or listen to their messages. And a study done at Kaiser Hospital System that implemented text messaging, they did a pilot program and saw a 3/4 percentage point improvement in no-show rates just by doing texts, which resulted in $150 savings per appointment. And so as we all know, no-show rates result in lost revenue, but more importantly, it results in lost opportunities for you to have contact with your patients for preventative care services, for chronic care services. So no-show rates are certainly much more than a revenue issue. It's a patient quality and a patient safety issue. So we really want to work on getting our no-show rates down. Certainly calling patients to remind them when they've missed appointments is a good strategy. I do want to also, one last thing, the scheduling on that bottom point there. Scheduling appointments within a reasonable time. We just talked about measuring the availability of your appointments. If patients have to wait a long time to get appointments with you, it's more likely they're going to forget about it or miss it. So the quicker turnaround times that you have, the better results you're going to have in terms of no-shows. Also, the more you switch to open access scheduling, the less likely you're going to have high no-show rates. And that's because you're accommodating patients as they perceive that they need care. And when patients call you and are able to get same-day access to you, you run a lot less risk of having high no-show rates. This is an example of a report that you could produce to NCQA. This is from the 2011 standards, but just to show you an example of what it may look like. And this practice, all they did is they produced a little Excel file that showed how many appointments they had over a 3-month period of time. Or it may have been actually 4 or 5 months. How many arrivals they had and how many no-shows they had. And so if you look at this, they actually used this to compare no-show percentages of their whole practice to no-show percentages with Medicaid to see if Medicaid was worse than the rest of the practice. And what this quantitative data showed them was their Medicaid no-show rates were about 4 percentage points worse than their overall practice no-show rates. So it enabled them to think through how can we focus on our Medicaid patients where there's a disparity of care. Also, a couple other examples of some good quality improvement project ideas. A team of clinicians and staff at a family practice in Wisconsin, they undertook a systematic review to identify how can we better eliminate no-shows. And so what they did is they reached out, this seems pretty simple, I mean, it's not rocket science, they reached out to their most frequent no-show patients and they asked them, why are you not coming? And based on that research and the data that they collected, they developed a 3-pronged approach which involved educating the patients about the importance of showing up and the impact that no-shows have both on the physician practice and on the patient's quality of care. They started a double booking process where there are patients that were frequent no-shows, they would double book those appointment slots in case the patient didn't show up. So at least they had someone coming up, someone to see during that time period. And then they did as much open access, advanced access scheduling as they could. And after these interventions, which were pretty simple, they saw their no-show rates fall for their frequent flyers from almost a third of the time down to 17.7%. So some pretty good efforts. And one thing that we want to help you think through are your own quality improvement projects. If your no-show rates aren't where you want them to be, we want to help you think through creative and innovative ways that your specific practice can address your no-show rates. And that's what Factor 6 is all about. Factor 6 is where NCQA requires you to pick one of the 5 factors that you've already been doing quantitative research on, and then in areas where you want to improve, NCQA asks you to do a quality improvement project. One thing I do want to say about this quality improvement project is this is not a fancy peer-reviewed journal type quality improvement project. This is more, think 5th grade science fair, where you do the plan, do, study, act cycle. If you've heard the PDSA cycle, all you do is you make a plan, you look at your data, and you develop some process changes that you think will improve. Let's just give an example. Let's say it takes 38 days for your patients to schedule a sports physical. And you say, you know what, I don't want it to be 38 days. I think I'd like it to be 14 days. Let's shoot for 14. And so you make a plan. You say, what changes could we make that could make the wait time for sports physicals that we think would reduce it from 38 days to 14 days. And then you plan it, and then you start doing those things. The process changes that you plan, you do them, and you see if they work. And in order to see if they work, you've got to study. You've got to have some quantitative measurement to see, is this really working? A hunch or a feeling is not enough here. You do need to have quantitative data to be able to determine whether or not you're truly improving. And if what you planned and did does not work, well, you've studied it, it doesn't work, and you act based on those studies to improve again, and you go right back through the cycle. So it doesn't matter as much that what you do doesn't work. NCQA is more interested in you working through these quality improvement projects and trying to improve. Of course, we would love for these projects to work, but NCQA does not penalize you if your project is not effective. But what it should do is, if your project's not effective, it should motivate you to try something else until you come across an idea that can work. And again, our SCMA team is here to help you think through these ideas and come up with good project ideas. This is just an example of an NCQA quality improvement project under the 2011 standards. This was that practice that had the no-show disparity rates between their Medicaid and general populations. And if you look again on that third, or if you look on the third column, their Medicaid population no-show rate was over 10%, and their overall no-show rate was about 6.5%. So if you look on that 5th column, and I'm not going to read the whole thing, but these are the interventions that they planned. It wasn't anything complicated. They basically just decided, we're going to start actually tracking this to see who these patients are. And once we've identified these Medicaid patients that are missing, we're going to follow up and try to reschedule, but also emphasize the need to show up for visits. And for those exceptionally frequent no-shows, they were going to get in touch with the Medicaid caseworker for that patient and try to provide additional assistance and determine what is it that's preventing the patient from coming. And if you look at their scores over a period of 3 months, and we certainly can't guarantee that any of your efforts will be this successful, but they may be, they went from a 10% rate down to almost 5.5% over a period of 3 or 4 months. So it was a very effective project for them, and they're certainly going to continue to do what they've been doing, but can also continue to build upon what they've already done. This is just another example of a quality improvement project, just to show this is not rocket science. This is not something that NCQA is necessarily measuring for Standard 1 Element A, but it just gives you another idea of what a quality improvement project looks like. And in this case, a Florida County Health Department adult primary care practice, which was a very busy practice, noticed that there was a lot of, there's a bottleneck at the patient waiting area. The patients were having a hard time getting back into the waiting rooms. And so again, they just studied it. They looked and said, what are we doing that could improve this? And when they did their research and thought about what process changes they could make, they realized that the folks at the front desk were handling too many tasks. And so the tasks that they were doing were taking them away from handling the patient intake. They also realized that patients were confused about where they should go when they came in. And so what they did is they developed a temporary receptionist desk that helped direct patients in the right direction. They divided some of the duties from the front office staff so that the intake staff could actually do intake and get the patients through that flow quickly. And they also had an individual sign-in sheet that would help protect the patient's privacy, but also streamline the process. And again, these aren't complicated solutions, but what it does take is it takes the practice using time to take a step back and take a deep breath and look at their practice and study it a little bit and come up with good ideas for how to improve their care. And so this project that we just talked about, it did end up improving the front-end patient flow, eliminated congestion. It had fewer errors because the staff weren't so divided amongst what their work was. And so all in all, it resulted in higher patient satisfaction, but also better clinical workflow for the practice itself. Let's move on to Standard 1 Element B. And our focus was really on Standard 1 Element A during this presentation because that's the must-pass, but we will spend a few minutes on Element B and Element C as we conclude here. Element B is all about 24/7 access to clinical advice. NCQA wants to know, how are patients getting access to you over the phone and over the internet during office hours and after office hours? And then how are you documenting the clinical advice for the patient in the patient's records? So if you look at Factor 1 here, Factor 1 is all about how do our clinicians have access to patient records when they're not on site. So when the office is closed, can the clinicians get access to the EMR? So all NCQA is looking for that as a policy to make sure that your clinicians have access to your EMR off-site. Now with respect to Factor 2, which is a critical factor, which means to get the full points for this element, you've got to do this one. This is basically asking, when patients call in asking for clinical advice, how quickly do we respond to them? And how are we measuring this? And we'll talk more about that in just a second. Factor 3 is just like Factor 2, except it's about patient portal or other types of interactive electronic systems and clinical advice being given over that system. And again, this is clinical advice. Let me emphasize that. This is not refill requests or lab results or setting appointments. This is clinical advice calls and how quickly are you responding to clinical advice. And then Factor 4 is all about documenting the advice that you give in the patient's records. So let's just do a quick dive into these specific factors. So in Factor 1, like I said, this is for getting access to medical record information when the office is closed. This just requires a documented process, so nothing that's too difficult. Factor 2 also requires a documented process, but then requires a report that monitors when the calls are coming in, how long you've allotted to return phone calls for clinical advice, and then when that call is made back. Most practices that I've worked with in the past, they really have done kind of like we'll respond to all calls in the morning by lunch and all calls in the afternoon by the close of business. Or some will say we'll respond to all semi-urgent calls same day, all non-urgent calls next day, and of course any urgent calls need to go straight to 911. And so there's really a lot of flexibility for how you define what timely clinical advice is for your practice, but once you define it, NCQA wants you to measure it. This is an example from one of the practices we work with where their response time for urgent or kind of semi-urgent clinical advice was an hour, and then for routine clinical advice was 24 hours. And if you look at this practice, they just basically created a spreadsheet. We've got templates like this for you that you can fill in, and they just filled in this template for a week's period of time for when the call came in, what the call was about, when it was returned, and whether it met the practice's standard. I do want to say that NCQA does not require you to meet your own standard. They're more interested in you measuring to see whether or not you're meeting your standard. Factor 3 is the same as the previous factor, except this is about portal or electronic communication. So your template's going to look very similar, and it's going to be focused on the portal advice that you're giving. Now, if you don't have a patient portal yet, then obviously you wouldn't do this particular factor. And NCQA, like I've said before, does not require you to do all factors to pass, but if you want to be a level 3 top level practice, you're going to have to do most of the factors. And this one typically is an easier one to pass than others. And then finally, Factor 4 is how do you document the clinical advice in the medical record? So when you're getting these calls during and after office hours, when you're getting these portal requests during and after office hours, and you're giving clinical advice to the patients, are you documenting the clinical advice that you're giving? And I'll say that most of the practices I've worked with over the last year and a half or so don't really have a problem with this because in their EMR, they'll have a telephone encounter or some similar type of thing for the portal where the physician will get the question, type out the answer that they want to give, and typically the nurse or medical assistant will respond to the patient with the physician's medical advice. And also there's protocols that many practices have set up where nurses or others can provide clinical advice over the phone under the management direction of the physician. This is just one example of proving to NCQA that clinical advice is being given. NCQA requires 3 examples, one during office hours and one after office hours, and the other one could be either. This is just real simple. You just take a screenshot of a telephone encounter from your EMR. I believe this is from eClinicalWorks, and it just shows that you're responding to the patients and providing clinical advice over the phone. Element C, this is one that you're going to find will be either really easy or next to impossible. And the reason for this is that Standard 1 Element C is typically tied to a patient portal. So if you have a patient portal, this one will be fairly easy for you as long as you're meeting these percentages. And the percentages that you see here, like the 50% of patients have online access for factor 1, 5% of patients view from factor 2, clinical summaries for factor 3, 50%. These percentages are aligned with meaningful use. So if you have met meaningful use for these particular factors, all you have to do is produce a meaningful use report to prove that you've done these things. And so this is an example from one of the practices we worked with last year, and all they did is they produced a meaningful use report that showed they were meeting the percentages. These are for the old 2011 standards, but you'd have a similar report for the new 2014 standards. And then we actually help you produce your report like this from a screenshot, and we put text boxes and arrows. We'll help you with all this, but this is how you prove to NCQA that you've met Standard 1, Element C, factors 1 through 3. And then some practices will use the actual screenshots from their patient portal to prove that they've met factors 4 through 6. And again, this is just a screenshot that we took out of practice, and then we developed these text boxes and arrows to point out where the patients are able to get appointment requests, have two-way communications, prescription refills, etc. And again, this is under the old standards, but the new standards would be very similar. So this is one that will be either real easy for you, or if you don't have a portal, this one will be next to impossible. And again, you don't have to do Element C to pass, and you can even hit Level 3 without doing Element C, because Level 3, if you don't do Element C, you only lose 2 points overall, and you can give up 15 points and still hit Level 3. Well, we are now coming to the end of our webinar, and the intent of this has been to be more of a general overview of Standard 1, showing you some specific examples along the way of what we've been able to use to prove to NCQA that we have met these standards, elements, and factors. But the most important work that is left to be done is really inside your practice. We will come visit your practice. We will help you think through these issues. We will help you with the documentation, and we will even help you upload it to NCQA survey tool. We really are a full-service consulting project that can help you from A to Z. If you don't require that level of assistance but still have questions, we're also more than willing to come visit with you or talk with you over the phone or answer emails. And so please, we welcome your feedback. We welcome your questions. Again, you can see my email on the screen, scotth@scmedical.org. Please email me with any questions or feedback that you may have. And we look forward to speaking with you again next month, where we will be covering Standard 2 of NCQA's 2014 guidelines. Thank you for your time, and I look forward to connecting with you all over the email and over the phone and in your practice in the next couple of weeks, and with a webinar coming up in June on Standard 2. And until then, we'll see you then.